Okay, so if someone has had a mastectomy, single, double, what are the frequently asked questions? And you say you give a talk about this, so let's start there.
You know, when women come in for breast cancer reconstruction, that's really an extensive discussion we have. There's really two major things we talk about, and that's whether we do it in an immediate sense, okay? So we can do the reconstruction at the time of the mastectomy, or we can do it in a delayed sense. And I have women that have come 5 or 7 or 10 years after a mastectomy.
Is that right?
That now feel that they're ready for reconstruction.
What is the best way in your opinion, or does it depend on the cancer?
It depends on the cancer, it depends on the patient's mentality and how prepared they are for the process. So that's why at the Comprehensive Cancer Center, we have a surgical oncologist, myself as a plastic reconstructive surgeon, we have a psychological evaluation, we have the hematologist oncologist, and the radiation therapist. So they can see everybody there. It helps us assess their sort of mental or how mentally prepared they are for the process. Not everybody is a candidate for reconstruction, and that's something to understand. Once we determine if they're a candidate for reconstruction and whether we're going to do it in an immediate sense or delayed sense.
So not everybody's a candidate.
Well, you know, some people with more advanced cancer.
Okay.
You know, obviously, my role as a reconstructive surgeon is secondary to the treatment of cancer. So we need to make sure that we treat the cancer appropriately.
So once the cancer, okay, they've had the mastectomy, the cancer's under control, they're in remission, we're confident about remission, then they're candidates?
Some women at that point are candidates. Once again, you know, women, once we determine if they're a candidate, from the type of cancer, some women are candidates for immediate reconstruction. So they come in for the mastectomy, we do a simultaneous reconstruction while just one surgery, okay? So that's the first determination, whether we do it in immediate or delayed sense. The next big question for a patient is whether we use an implant or we use their own tissue. And once again, the treatment plan, just like for a cosmetic patient or a reconstructive patient, is tailored specifically to the patient, their desires, and what we're able to safely obtain.
Okay, then tell me a little bit about, and what are their frequently asked questions? Obviously, safety is a big thing, but what are their other questions they have aside from safety?
The biggest thing, to be honest with you, is the finances. They're always worried if it's going to be covered. And
is it?
Yes. In 1998, there was a lawsuit that was raised, and now insurance not only provides for reconstructive of the affected breast, it also covers the unaffected breast for symmetry. So if somebody comes in and they have right breast cancer and we do a reconstruction, it's usually a 2 or 3 stage process. Part of that process is revising or doing surgery on the contralateral breast for symmetry, and that is something that is covered by insurance.
Does it include the implant?
Absolutely.
The insurance?
Yes.
And how, okay, so somebody, let's say they catch this on the internet or whatever, how many years later, let's say that this is new news to them, 5 years ago, they're 8 years in remission.
They can come in at any time. There's no set time.
Are there a lot of people out there like that, by the way?
I think there are a lot of people out there that didn't even realize that reconstruction was an option, and now a lot of women feel that it's been so long that they can't come in.
What are their fears, by the way?
I think
of the ones that know they're candidates and do nothing, like they don't want to touch the area and get it going again.
The biggest fear is probably the risk of a complication. Okay. Women are worried that a complication could delay the treatment of their cancer, and I think that's the biggest hindrance that most women try to overcome, or the biggest reason a lot of women don't even seek reconstruction.
Help me lower their fears then. Help lower their fears, I should say, not me.
Well, you know, when a woman comes in for reconstruction, our talk encompasses all of this, and I go through specifically the risks that come through this. Now, the risks are a little bit higher than a cosmetic procedure because of the stress on the body, the presence of cancer, the prolonged surgery times that come with it. But still, if you look at the actual percentages of complications, it's still relatively low. And so once patients understand that, and they understand that whatever option we go, it's not going to delay the treatment of their cancer, that opens up an entirely new avenue for a lot of patients.
Okay, now we should mention, by the way, for people that see this on YouTube and other social media, that you're a doctor that gets referrals from cancer centers.
Correct.
So you are also very, you have a deep understanding of cancer.
Yeah.
And who's a candidate, who's not. How important is that, choosing a surgeon that's not just a cosmetic surgeon or plastic surgeon, but somebody that really deals with this?
Well, I think that it's important for 2 reasons. One, understanding the process and understanding that it's just not a simple or single procedure is important.
Okay.
And encompassing, the mental anguish and stress that the patients go through is critical. The other thing is, just like with our cosmetic techniques, our reconstructive techniques continue to evolve. So if you're not going to a surgeon that does a lot of reconstruction, they're probably not going to be up to date on the recent techniques.
Okay.
And those recent techniques not only give us a safer procedure, but really give us a more natural
So
result.
you can give them a natural looking breast.
Absolutely.
What about the nipple?
The nipple, it's odd because a lot of women, that's one of their biggest concerns. And, we're able to reconstruct the nipple rather nicely nowadays, not only with the assistance of tattooing, but, through some of our surgical techniques. And getting, we create a nipple. Women that have had a unilateral mastectomy or one-sided, we use the contralateral breast to determine the location of the nipple. Women that have had a bilateral mastectomy, we pick the location of the nipple and create it there so we have symmetry. When you look at a woman from a breast standpoint and talk about symmetry, there's three things you look at. You look at breast volume, you look at breast shape, and you look at nipple position. And if we can have symmetry of those three things, most women are very happy with the results. Whether we're talking cosmetically or reconstruction, those are the things that we try to achieve.
For those that get the procedure immediately on the day, use the same nipple?
No, there's...
So you always use a...
Well, this is really a hot topic in cancer treatment, is whether or not to do a nipple-sparing mastectomy.
Oh, interesting. Okay.
So the mastectomy traditionally encompassed removal of the nipple, okay? Recently, and it's once again met under a lot of controversy, I'm not the surgical oncologist, so I don't make that determination, but recently there's been a move to try to preserve the nipple. And so,
what are your thoughts? I mean,
well, my thoughts, I look at it this way: it's an individual basis that people make this decision. It depends on the location of the cancer.
Are there cells that travel to the nipple?
That is the thought process, and that's why the surgical oncologist will look at that and say, because of the location or the type of cancer, it's safe to do a nipple-sparing mastectomy. The thing I will tell you from a reconstructive standpoint is we get a very good result with a reconstructed nipple. So I don't want a woman to choose a nipple-sparing mastectomy simply out of the fear that she will not have a natural-looking nipple afterwards, because we can do a great reconstruction. So I don't want that to be the determining factor on whether or not to do a nipple-sparing mastectomy. If the patient meets with the surgical oncologist and they feel that that's oncologically or from a cancer standpoint sound, then that's fine. But I don't want them to make that decision based off a cosmetic result.
Now, I know, just from, visiting hospitals and some of these cancer centers, everybody gets a lot of advice before, after, during the procedure. Experts come from all over the place. What's some misinformation about breast reconstruction that maybe you could lay to rest?
Well, I think the biggest misinformation about breast reconstruction is that some people are not candidates. I mean, there are a majority of the patients for breast cancer are candidates for reconstruction.
They are, aren't?
They are.
They are.
There are a small percentage of women that are not, and even not being a candidate for reconstruction generally means a candidate for immediate reconstruction. They can always come back in a delayed sense for reconstruction. So,
good.
And I think that's the biggest thing for women to understand. Less than 25% of women that have mastectomies go through with reconstruction. And a large portion of that has to do with lack of knowledge or availability for the reconstructive process.
Okay, good. I want to thank you for the information. If they want to know more about you, they could visit your website, ask their oncologist about you.
Absolutely.
And get information there. Thanks a lot.
Pleasure. Thank you.
Good.